All right, thanks for joining me. We've got a lot to cover, so let's dive in. My name is John Kanab. I'm an anesthesia-trained interventional pain management specialist. I run an independent practice in Wilmington, North Carolina, where we've been treating spinal pain for 24 years. My goal tonight is to go over my approach to lumbar spine pain. I'll briefly review our past attempts at non-surgical management and show you why some of the current industry-sponsored solutions may be destined to fail, much like their earlier attempts. Most importantly, I will also show you why we should be thinking of disc issues as being a multifaceted problem, one that is mechanical, chemical, and in some cases, infectious in nature. I have no relevant financial disclosures. Here's the issue. When it comes to the treatment of lumbar spine pain, especially discogenic pain, and treatments that are covered by insurance, we are dead in the water. We are no better today than we were in 2001. In fact, we have fewer options now than we did 23 years ago. So some of us have been using PRP and BMC, but what do we use and when? And how do we convince other people and even ourselves that it actually works? To make matters even more complicated, we have people flying all over the world to get $70,000 illegitimate birth tissue-based stem cell procedures, and the FDA threatening to shut down the whole field of orthobiologics. This is true. We actually reused and resharpened the spinal needles every night at my training hospital, Virginia Mason Medical Center. My point is, don't tell me I'm not old. I have been around the block and I have seen it all. Some of the old stuff actually did work, but as with most things that are good in medicine, they become investigational, so we can't use them anymore. So industry steps in to fill the vacuum, and we have things like stem cells in a vial or ground up disc also in a vial that we can buy and inject. Or we can use autologous products, meaning point of care blood, bone marrow, and fat that can be processed in an FDA compliant method to inject back into the patient during the same procedure. So does PRP or stem cell therapy play a role in the treatment of discogenic pain? Let's do a 3-minute tour of the history of non-surgical disc treatments. Here is IDET, or intradiscal electrothermal coagulation. Great concept, promoted by the Saul brothers, just heat and treat. Problem was, it was only partially successful in about 30% of patients. And oh yeah, you can sometimes heat up the cauda equina, which is not good. So for IDET, it was a fail. Nucleoplasty was cool. The anode cathode array at the tip of this device created a plasma field which vaporized portions of the nucleus pulposus. Even though it probably didn't work the way they told us it worked, it did actually work, especially for patients with radicular components. But all of a sudden, this 15-minute procedure became investigational and non-covered. And this was way back in the day when us doctors wouldn't even think of asking patients to pay cash for a procedure, so it just kind of died. This is the probe tip. And so another fail. Here's a great idea. Take Augmentin for 100 days, really. So about 2006, researchers were actually proposing the idea that back pain could be cured with a 100-day course of good old Augmentin. What could go wrong? Well, C. diff enterocolitis? Don't worry about it. Was this the end of pain management and spine surgery as we knew it? Maybe not. Among other reasons that taking Augmentin for 100 days, a 1/3 of a year, was a bad idea was good old conflict of interest on the part of one of the authors. While he was publishing and speaking on this miracle of discovery, he was also setting up a side gig to train doctors how to be MAST certified. MAST standing for, I don't know, miracle antibiotic scam therapy. So yet another fail. Okay, so what about injecting methylene blue into the disc? Makes sense, right? It does? Yeah, well, oddly enough, there are some anti-inflammatory and immune modulating effects of methylene blue, but in terms of the early research, it really seemed as though the majority of the data with methylene blue was coming out of one particular group that may have been promoting the treatment as a one-size-fits-all cheap solution that could be given to the entire populace of a certain country. Methylene blue intradiscal remains a controversial treatment option and is not FDA approved. You see the pattern here, fail. Well, here's one of the early stem cell and a vial companies, Mesoblast, an Australian company. Initial data looked good, except for the fact that the higher dose patients didn't do as well as the lower dose patients. And as is the case with any early phase clinical trial, and when the company is publicly traded, the investors come calling. And as it stands now, Mesoblast stock is down about 80% from its peak, and its offering for treatments of discogenic pain is yet another fail. Fast forward to 2020, Vivex comes out with this Viadisc stuff. You know, this company was selling a questionably FDA compliant, 351, 361. I couldn't get an answer on that. It's an off-the-shelf preparation of ground-up nucleus pulposus to inject into degenerated lumbar discs. The product cost was about $9,000 per vial, and you had to inject it in a surgery center or a hospital, and that doesn't include the facility fee or professional fee, so you can easily triple that $9,000 cost for each disc in terms of pricing. They published their vast trial results. I'd been talking to the authors and sponsors of the study for 2 years, and I still couldn't get an answer about what was actually in the drug and why injecting allogeneic nucleus pulposus into a damaged disc was even a smart thing to do. I mean, the nucleus pulposus is the stuff that aggravates nerves to begin with, right? I also wondered why the patients receiving placebo, which was saline, seemed to do just as well as the patients receiving the active drug. So the FDA finally got around to asking the same questions I was asking. And spoiler alert, for those of you who are on the TOBI webinar with Scott Bruder on April 24th, you already know this, but Vivex, the manufacturer of Viadisc, was finally told that they were in fact manufacturing a drug and were given a cease and desist order, resulting in this product becoming yet another fail. Keep your eyes on Notogen and Discgenics. That first company with that hot alcohol gel injection into the spine, though, that's a hard pass for me. No, thank you. They've actually already reported in humans extravasation of the gel from the disc into the spinal canal, requiring a small surgery to remove it. So anyhow, well, maybe there are some near future off-the-shelf options, but so far industry has failed us. So what do we do? Well, in 2017, Patin and his colleagues studied 26 patients over 3 years and found that in patients receiving more than 2,000 colony-forming units per cc of bone marrow concentrate, there were no adverse events, and patients' VAS scores were reduced by 75%. Both ODI and VAS improved in patients receiving the 2,000 CFUF count, and the authors proposed that the bone marrow stem cells might be providing natural healing mechanisms to the avascular disc tissue. They also proposed that bone marrow concentrate might have an anti-inflammatory mechanism of action, which might lead to improved cell repair and tissue regrowth. Other authors proposed that in addition to its anti-inflammatory effects, bone marrow concentrate might also have antibacterial properties to it. 80% of patients in the study were able to avoid surgery during the study period. And 5 years later, Sairam Otlery teamed up with Matt Murphy, one of the authors in the Patin study, and took another look at intradiscal BMC. However, in this study, they also performed injections of BMC into the facet joints, ligaments, intralaminar and transforaminal epidural space. Patients in Otlery's study had very high CFU counts, and there was a positive correlation between CFU count and improvement in ODI at 1 year. Patients in the active group of this study also noted rapid and sustained improvements in VAS out to 12 months which were statistically significant when compared with the control group. So we have two pretty compelling studies, and intradiscal BMC looks pretty good, right? Well, not always. This is what can happen and did happen and does still happen to some patients getting intradiscal bone marrow concentrate. That happened to us, 2 cases of discitis over 5 years ago, one for me and one for my partner, our only cases of discitis in a combined 48 years of spinal medicine practice. And in private practice, interventional pain, 1 infection is too many. We had 2. So we stopped doing intradiscal bone marrow concentrate. So for us, in terms of disc solutions, we were again dead in the water. Our solution was to treat patients instead with a functional spinal unit approach, basically injecting everything but the disc, including the facets, epidural space, iliolumbar, interspinous and supraspinous ligament, SI, sacrotuberous, paravertebral muscles, and it works really well, but it may not sufficiently address the disc. And for some of our patients, the FSU approach, as comprehensive as it is, really didn't get them to the level of pain relief and functionality they were looking for because we didn't treat the disc. So we began looking at intradiscal therapies again. Could intradiscal PRP be an option for the disc component? And if we're thinking about intradiscal PRP, what type, what dose, and what's the rationale for using PRP in the disc? Could PRP help us to treat all 3 aspects of disc pathology, including mechanical, chemical, and infectious? What this picture doesn't show are the inflammatory changes that can happen in the injured disc. It also does not show the motic changes which can happen adjacent to the discs when they're injured. Why do motic changes happen, and why do discs become inflamed? You remember the 100 days of Augmentin? Well, they weren't all wrong, actually. This is a recent study looking at the role of Cutibacterium acnes, or C. acnes, previously known as P. acnes, in chronic low back pain. This group looked at a total of 256 samples, that's 53 discs, from 23 patients undergoing surgery, and found a C. acnes prevalence of 34.8%. 34.8%. Even more interesting, they found that patients who were positive for C. acnes at the time of surgery were 4 times more likely to have neuropathic pain at 6 months following surgery compared to those who are negative for C. acnes. So stop here for a second and take a look at these numbers. Even if you've fallen asleep by now, wouldn't you want to try to kill these bacteria at the time of a procedure? How could you do that? Well, maybe you could achieve that with PRP. What kind of PRP would be able to kill bacteria? Meredith Prysack and her group found a direct relationship between absolute cell count and decreases in bacterial viability for granulocyte counts, but not for monocyte, lymphocyte, or platelet counts. So the specific type of white blood cell in our PRP may be important when we're talking about antimicrobial activity. Greg Glutz and his colleagues also showed that leukocyte-rich PRP with high granulocyte counts was very effective at reducing C. acnes counts at 48 hours. So having high levels of granulocytes in our PRP seems to be important for disc therapies. What else kills C. acnes? Well, if you're a C. acnes bacteria and you're exposed to gentamicin at concentrations of 500 mics per cc, there is a 99.9999% chance that you'll be dead at 48 hours. This graph shows a 6 log kill rate at 48 hours for C. acnes exposed to gentamicin, 500 mics per cc. Easy way to remember this is that the log kill rate is just the number of nines you use. In this case, it's 6 nines, so that's 99.9999% effective. So now we may be onto something. We have both leukocyte-rich PRP and gentamicin that are killing bacteria, which are present in about 35% of us with damaged discs. And we've also got high levels of growth factors from PRP that may be helping to slow down or even potentially reverse disc degeneration. But does it work? So this is the image of my accountant suffering from multi-level degenerative disc disease, 3-level Modic type 1 change, and severe stenosis at L1-2. He was miserable. None of my surgical colleagues wanted to touch him, and so we injected leukocyte-rich PRP into his intervertebral disc at L1-2 and L2-3, along with the FSU technique I showed earlier. This is his MRI at 3 months after the procedure. He was reporting VAS reduction of 80% and significant improvement in ODI. Modic changes have improved slightly, but the stenosis has completely resolved. He's back to golfing, traveling, and accounting. I haven't seen or heard from him in 18 months, except for him to ask me to sponsor a golf tournament. This is a 44-year-old female with chronic axial low back pain due to high intensity zone and annular tear. She was very anxious about having her disc injected, mostly because of the fear of infection. She did a lot of Google MD work. To make things even more interesting, I couldn't use contrast because she had an allergy, so I really couldn't see where the PRP was going. We injected her in February of 2023, and these are her images from prior to the procedure showing the high intensity zone, which was persistent over a number of years. This is another pre-procedure scan showing the high intensity zone at L5S1. And this is the high intensity zone appearance at 6 weeks following intradiscal PRP. These images are actually from a pelvic MRI we got for different reasons, but I asked the radiologist to get cuts of the bottom 2 discs, which they were kind enough to do. And we see the result with the decreased signal intensity at that prior persistent HIZ. These are some images from Greg Lutz's book, also showing improvement in appearance of HIZ at 3 months following intradiscal PRP. Read this book and buy some copies for your patients. In my opinion, it may be the most important piece of work that Dr. Lutz did in his entire career, leaving us a lasting legacy for all of us to share with our patients. But how about the concept that stem cells are better than PRP? Shouldn't we be using BMC for disc pain? Is this true? Not really. If you look at the data from Anu Nuvani and colleagues who performed this placebo-controlled head-to-head comparison in 57 patients receiving intradiscal PRP or bone marrow concentrate. The outcomes at 12 months were identical. No difference between PRP and BMC. In terms of which is safer, PRP or BMC, I think you already know my opinion on that. But how long does it last? This graph is from a survey of 29 patients who previously received intradiscal leukocyte-rich PRP. These patients are followed out up to 9 years and are still reporting durable, meaningful results in terms of VAS and SF36. These patients are cured. So we have used 3 registries over the past 7 years, and I encourage all of you to consider enrolling your patients in Data Biologics or something of similar quality. There are a number of them out there. These are our data from our clinic showing pain scales in patients receiving intradiscal and FSU PRP with 12-month outcomes shown here. The vast majority of our patients need much more than simple intradiscal injections, since most of them are in the older age group, suffering from CBS or crappy back syndrome. The reason for the smaller N here, which is 82, is that I am enrolled in the pro-level registry and my partner is not. This allows me to compare my results against the registry as a whole. Here, the NPR data in 82 patients over 12 months compared to the registry as a whole. And here are the ODI data in those patients over the same 12 months. So whatever we're doing, it seems to be working. And these results are in patients getting only platelet-derived procedures, except for a small few who got BMA for facets and SI joint. None of the disc patients got intradiscal BMC or any other product. They have all been treated with high-dose leukocyte-rich PRP. So we should all consider discogenic pain as having 3 components to it. Earlier technologies failed because they were only taking care of 1 or at most 2 components. Is intradiscal high-dose leukocyte-rich PRP as good as BMC? Seems to be the case, but time will tell. Currently, based in large part on the work done by Greg Lutz and others I presented tonight, I'm convinced that with the combination of intradiscal gentamicin and high-dose leukocyte-rich PRP, we finally have something that allows us to help our patients without hurting them, without burning any bridges along the way. That's my talk. Thank you for listening. Here are some references and a few more. The best way to contact me is through LinkedIn or on the Mighty Networks TOBI platform. And thanks again.